Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very important topic, the cerebrospinal fluid. The cerebrospinal fluid and the core concepts. Introduction. What is cerebrospinal fluid? Cerebrospinal fluid is an ultrafiltrate of plasma. Cerebrospinal fluid is an ultrafiltrate of plasma. Cerebrospinal fluid surrounds the brain and spinal cord and acts as a cushion and protects against the head injury. Because there is cerebrospinal fluid, when there is head injury, the brain does not go and hit against the skull straight away, because there is a protective cerebrospinal fluid which surrounds the brain and spinal cord. So it protects the brain against the head injury. One of the important functions of the cerebrospinal fluid. Cerebrospinal fluid also carries nutrients to some extent to the brain, and it removes waste products from the brain. Especially in sleep, one of the important functions of the sleep is to remove waste products from the brain and let it into the cerebrospinal fluid. Sleep is an active process, not a passive process. Most of the waste material are removed from the brain into the cerebrospinal fluid during sleep. So cerebrospinal fluid not only supplies nutrients to the brain but also removes waste from the brain. Brain actually has got a lot of weight. So to decrease the weight when it is surrounded by the cerebrospinal fluid, it gives a kind of buoyancy and therefore reduces the weight of the brain. So cerebrospinal fluid is very important. It is an ultrafiltrate of the plasma. It surrounds the brain and spinal cord and protects the brain against the head injury. It takes nutrients to the brain and removes waste products from the brain. It gives buoyancy to the brain and therefore reduces the weight of the brain. So cerebrospinal fluid is very important and very vital. The cerebrospinal fluid, how is it produced? As I said, cerebrospinal fluid is nothing but an ultrafiltrate of the plasma. We have two lateral ventricles, third ventricle and the fourth ventricle. The ventricles are named third and fourth, but there is no first and second because there are two lateral ventricles. So two lateral ventricles, third ventricle and the fourth ventricle. The cerebrospinal fluid is formed by choroid plexus in the ventricles, especially the lateral ventricle, third ventricle and fourth ventricle. So how it is formed from the choroid plexus, we'll just discuss in a few minutes from now. But suffices to say as of now is cerebrospinal fluid is formed from the choroid plexus, from the ventricles, especially lateral ventricles. From the two lateral ventricles, it comes through the interventricular foramen of Monro to the third ventricle. From the third ventricle, it goes through the cerebral aqueduct in the midbrain to the fourth ventricle. The fourth ventricle actually is present between the pons on one side and cerebellum on the other side. From the fourth ventricle, there is foramen of Luschka and foramen of Magendie, which is a medial opening. These are lateral openings, and central canal. So it goes underneath, it goes below to supply the spinal cord. It exists from the lateral side and supplies the entire brain and runs in the subarachnoid space, the covering of the brain. So the central part of the brain, there is cerebrospinal fluid, and the covering of the brain and spinal cord also there is cerebrospinal fluid. Once the cerebrospinal is formed and starts circulating, it is reabsorbed back in the arachnoid granulations. Remember, I told that cerebrospinal fluid circulates in the subarachnoid space. We have arachnoid granulations from where it is absorbed into the superior sagittal sinus and then into the jugular vein. So very easy and simple to understand. From the artery, the choroid plexus, it enters the ventricles. From the ventricles through the arachnoid granulations, it enters the venous system. So from the artery to the ventricle, from the ventricle to the veins, back in the blood. Right. We have at the microscopic level the blood, the capillaries. There are tight cells, endothelial cells. Now in the ventricle, they are known as choroid plexus, where they are in the form of, they are known as cuboidal cells. So cuboidal cells of the blood vessels, they are tight junctions, so they will not allow anything in the blood to get freely into the ventricle. They are tight junctions. Only few substances can enter. The entry of the few substances from the blood into the ventricle through the tight cuboidal cells is through the energy dependent mechanisms, the sodium potassium ATPase channel. So using the energy, few substances in the blood enters into the ventricle like sodium, chloride and bicarbonate. So hypertonicity increases, so it draws fluid towards it. So that's how the cerebrospinal fluid is produced. So along with it, some proteins, amino acids, sugar also enter into the ventricles. And it starts circulating in the subarachnoid space. At the level of the arachnoid granulations, it is reabsorbed back into the dural venous sinuses, that is superior sagittal sinus, through the pressure gradient. The pressure of the CSF in the subarachnoid space and granulation is always more than in the veins, and because of the pressure gradient, it enters into the veins. So the reabsorption of CSF from the arachnoid granulation into the venous system, superior sagittal sinuses, is pressure gradient, and the entry of substances from the blood into the ventricles through the tight cuboidal cells is through the energy dependent mechanisms, sodium, potassium, ATPase. So that's how CSF is formed, which is an ultrafiltrate of plasma. That's how it circulates in the brain, surrounding the brain and spinal cord, and it is reabsorbed back into the superior sagittal sinus. So the total volume of CSF is about 150 ml, that is 10% of the intracranial contents. According to the Monro-Kelly hypothesis, the intracranial contents are the blood, brain and CSF. The CSF and blood, they form about 10% each, 150 ml and 150 ml, and the rest is the brain. So we have plasma on one side and the CSF in the ventricles on the other side. So how do they differ? From the plasma, as it enters into the cell, there is normally no cell, and if at all there are cells, there are hardly from 0 to 5 cells, and all the cells are lymphocytes. Even if there is one neutrophil, it becomes pathological. Protein is 1% of the plasma. Glucose is about 60% of the plasma, and chlorides and magnesium are higher in the CSF than in the plasma. So the opening pressure of the CSF fluid when we try to take the cerebrospinal fluid out through lumbar puncture is about 10 to 15 centimeters of the water in the lying down position, and it's about 20 to 30 centimeters of water in the sitting position. So cerebrospinal fluid is nothing but an ultrafiltrate of plasma. So it has got only about 0 to 5 lymphocytes, proteins, glucose about 2/3 of the plasma, and the others like calcium and magnesium in fact are more in CSF as compared to the plasma. Right. There are generally no red blood cells in the CSF, but then when we do lumbar puncture and we injure the cells and then they take CSF out, the CSF may be admixed with the blood, which is known as traumatic tap. And this is on one extreme. The other extreme is the actual pathology in the brain, where there is rupture of the aneurysms present in the circle of Willis, which are in the subarachnoid space. The CSF is in the subarachnoid space. The vessels also are in the subarachnoid space. So when the vessels dilate, aneurysm, they rupture. The blood is also in the subarachnoid space. So when we do lumbar puncture and take the CSF out, the CSF in subarachnoid hemorrhage is also mixed with blood. So how do we differentiate a traumatic tap from the actual pathology, the subarachnoid hemorrhage? The appearance of the traumatic tap is hazy, where subarachnoid hemorrhage is red in color. And when we collect CSF in 3 tubes, as we come from the first tube is mixed with a lot of blood. The second tube, the blood level comes down. The third tube, almost it becomes clear if it is a traumatic tap. But if it is a subarachnoid hemorrhage, the bleed is continuing in the subarachnoid space. So in the first tube, second tube and the third tube, the blood is equally present. It does not decrease as we put the CSF into the subsequent tubes. If there is a traumatic tap, because of the fibrin content, the blood will clot, but if it is subarachnoid hemorrhage, there will not be any clot. And then if we spin the cerebro-spinal fluid, CSF centrifugation, if it is a traumatic tap, the red blood cells will settle down and the upper part will be very clear. Whereas if it is subarachnoid hemorrhage, because of the pigments, there will be xanthochromia, yellowish discoloration of the CSF if we spin the CSF fluid. So xanthochromia indicates that it is a actual pathology, the subarachnoid hemorrhage. Right, these are the important fundamental concepts of the cerebrospinal fluid. Now, having understood the basic concepts of production, circulation and absorption, we will see what are the normal constituents and what are the abnormal constituents in the various pathological disorders, especially infections. So when we take the CSF interpretation, the disease, the normal, we can diagnose pyogenic meningitis, tuberculous meningitis, fungal meningitis and viral meningitis. Normally the CSF appearance is clear, but if it is pyogenic meningitis, it appears cloudy because of the cells or the proteins. Whereas in tuberculous meningitis, it is usually clear, but sometimes it may appear hazy. The fungal meningitis or viral meningitis, the CSF is clear. So this is the appearance of the CSF in normal and pathological infectious conditions. Next, we look at the characteristic of the protein content. Normally the protein is about 20 to 40 milligrams per ml, normal. But in pyogenic meningitis and tuberculous meningitis, because of infection, body is trying to produce antibodies, so the protein content will be elevated. In pyogenic meningitis, it could be 100 to 300, and in tuberculous meningitis, it could be 100 to 1000 milligrams per deciliter. In fungal meningitis and viral meningitis, also the proteins will get elevated, but not to the extent of pyogenic meningitis and tuberculous meningitis. So proteins are elevated in all infectious conditions. Next is the glucose. Glucose is about, CSF glucose is about 2/3 of the plasma. So normally it is about 40 to 60 milligrams per deciliter. In pyogenic meningitis, the glucose fall is very low. The glucose is very low. It falls rapidly to the extent of being less than 10 milligrams per deciliter. So in pyogenic meningitis, the glucose level is going to be very low. In tuberculous meningitis, it will be moderately decreased, less than 30 milligrams per deciliter. In fungal meningitis, it is still mildly decreased, less than 40 milligrams per deciliter. And in viral meningitis, the sugar is normal. In viral meningitis, the sugar level in CSF is normal. Very, very important point. Because we diagnose viral meningoencephalitis when we see that the CSF sugar is normal. Then the cell count. Normally there are no cells. If at all there are any cells in the normal CSF, it is about maximum 5 cells, and that too all are lymphocytes. I would like to make a comment regarding this, that when we are testing for cell count, we have to do it within 60 minutes. 60 minutes of procurement of CSF, because the cells will degenerate, and therefore we have to immediately test the cell count within 60 minutes of procurement of CSF. The pyogenic meningitis, the cells are increased. They are trying to fight out the infection, so the cell counts are increased, but it is polymorphs and neutrophils. And we can make out the pyogenic meningitis by gram stain and culture. Tuberculous meningitis, the cells are again increased, more than 100 to about 400, but this time all are lymphocytes. So pyogenic meningitis, the cell increase is present, but it is polymorphs. In tuberculous meningitis, it is lymphocytes. Very important point. And we can do AFB stain, TB PCR and TB culture. Fungal meningitis, the cells are increased, the cell count is increased, it is about 50 to 200. Again here all are lymphocytes. And we do Indian ink for cryptococcal fungal infections, and we can do fungal culture. For viral meningitis, the cell count is less than 100 cells. All are lymphocytes, and if there is herpes simplex encephalitis and meningoencephalitis, it is we need to diagnose it. Because it's a highly treatable condition. You can give acyclovir and treat. In fact, of all the viral infections, HSV is very much amenable to treatment by giving acyclovir. So I've told so much of information, it may appear confusing. So we can have an algorithm or the final analysis. So when we take the cerebro-spinal fluid, how are we going to analyze and interpret it? Basically, we are looking at 3 constituents. 1, the proteins. 2, the cell. 3rd is the sugar. So when we procure CSF, we will look out for the protein content. If the protein content is elevated, there are 2 possibilities. 1, it could be infectious, or it could be an immunological disorder, because in both the proteins will raise. So first we check out on the protein content. If the protein content is elevated, it could be either infectious process, or it could be a immune mediated process. So to confirm it, the next step we do is to check out on the cell count, on the cell number of cells. If the number of cells are increased, then it is definitely infectious pathology. But if the cells are not increased and only the protein is increased, we call it as albuminocytological dissociation, and it is highly suggestive of Guillain-Barré syndrome. So when we first get CSF, the first step is to check out on the proteins. If the proteins are elevated, it is either infectious or an immune mediated problem. We look at the cell count. If the cell count is increased, it is definitely an infectious problem. If it is not increased, it is an immunological disorder like Guillain-Barré syndrome, what we call it as albuminocytological dissociation. So once the cell count is increased, we look at the type of the cell, whether it is neutrophils or lymphocytes. If it is neutrophils, it is going to be pyogenic meningitis. If it is going to be lymphocytes, it could be tuberculosis, viral or fungal. So the next step is we look at the type of the cell. If it is neutrophils, it is pyogenic meningitis. If it is lymphocytes, it could be tuberculosis, viral or fungal. So to confirm this, the next step, the 3rd step we do is to check out on the sugar level. If the sugar level is drastically fallen down, very much decreased, it is pyogenic meningitis. If it is moderately decreased, it is tuberculosis. If it is mildly decreased, it is fungal. If there is no decrease of sugar at all, it is viral meningitis. Such a simple algorithm, by just looking at the protein, cells and sugar, will be able to diagnose and establish the infectious pathology. Right. So what are the take-home messages? The three important points is that the CNS infections are treatable. The CNS infections are treatable, and therefore we should never miss the diagnosis. If we do not diagnose an untreatable condition or the condition which does not have treatment, it does not really matter. But if there's a treatable condition and if we miss out on it, it's going to really reflect very badly and poorly on doctors. From the patient's point of view, it's going to make a lot of difference. So first of all, CNS infections are treatable and therefore we should not miss this diagnosis. Second, the CSF analysis plays a very, very important and pivotal role in diagnosis of CNS infections. And therefore, a thorough knowledge of CSF is required by every doctor to treat CNS infections confidently. So what all I discussed, the CSF being an ultrafiltrate of plasma, the production, circulation, functions of CSF, and finally the analysis and interpretation of CSF for diagnosing intracranial infections. All these are the core concepts which I have discussed. And I hope you have really enjoyed listening to this lecture. If you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.